Well, good morning, everybody. Welcome to our Health and Hospital Committee meeting. I'm Supervisor Ken Yeager, Chair of the committee, and I will soon be joined by Supervisor Smidian, who is the Vice Chair of the committee. But we're going to start off with public comment, and we have a number of cards. We have at least 6, and so that means we will have 2 minutes per speaker. I will go ahead and read your names, and if you could just sort of come up and stand and then just follow each other. There isn't a microphone. It's built into that panel, so you can just come up to it and start speaking to us. So we have Tracy Corner, Jackie Lopez, Abe Hughes, thank you, Natalie Rangel, Logan Paulo, and Scott Largent. Good morning. Please come forward.
Good morning. Should I start?
Yes, right there.
Good morning, Board. Thank you for letting us speak today. My name is Tracy. I'm a rehabilitation counselor at Sunnyvale Behavioral Health, one of the PCBH. We're here today to express our concern about proposed reduction in direct line staff for our behavioral health clinics, the elimination of rehabilitation counselors, community workers, and peer support workers, we feel will have a very negative impact on the care of our behavioral health clients. The Santa Clara County Behavioral Health Mission Statement states, the public behavioral health system is successful in helping to ensure that all residents in need of public behavioral health services are physically and emotionally healthy, happy, and thriving in a safe and permanent living situation, part of a loving and supportive social network, involved in meaningful school and work activities, and safe from harm from the environment and others. As direct line staff, we all address these each in our daily work. We are the only staff in our clinics that can actually go out in the community where our members live and assist them out in the community. We often advocate with landlords. We go when clients are in PES. We're able to go see them, sign them up to our services, help them find housing. We provide crisis intervention. We do welfare checks. Again, we are the only staff that is able to go out into the community where our members live, work, and have their activities. Other roles that we play in the care for our clients is we are usually the only facilitators of supportive groups within the clinics, wellness recovery action plan, healthy living.
Thank you.
Thank you for your time.
Good morning.
Good morning. Good morning, everybody. My name is Jackie Lopez. I work at East Valley Behavioral Health, and I've been there for 11 years. It's great. I love serving the community there in East San Jose. I'm just a little concerned. I'm very concerned, and I'm a bit disappointed because I feel this is something that was proposed back in 2008, 2009, and fortunately, we were able to keep the specialty, the rehab counselors, the community workers as myself, and the peer support workers there at the clinic, which I think is just so important, especially in East San Jose. My community worker position, as well as my counterparts, it's Spanish-speaking designated, so we're at the forefront with the clients every day, and assisting, and interpreting with the psychiatrist there in the room. Whereas if they were doing it through the phone, it's completely different. Clients are not as open. They get misdiagnosed because they're not speaking up. They just don't feel comfortable. So I really am here more so for the clients. This would be devastating to this community, East San Jose, if our positions were to get, placed elsewhere. I understand the proposal is to keep us, but, move us to specialty. But I think it's very important to reassess and keep us there at East Valley because the need is great. And I'm honored to work with everybody that's here today and those that weren't able to make it. And we're just here to voice our concern and hope that things can be reassessed and we can stay. Thank you.
Good morning. My name is Abe Hughes. I'm an RC at Sunnyvale Behavioral Health. I'm here to share with the Board of Supervisors the RC's role in serving our clients, community, and clinic staff. Many of our clients are residents of Sunnyvale. They have moderate to severe mental illnesses. Many of these clients do not wish to transfer to specialty mental health clinics, as these clinics are not near their homes. Many of these clients have been at Sunnyvale for years and they feel established. It is important to have specialty mental health services in all cities throughout the county to better serve our residents. Many of our clients struggle to keep appointments at Sunnyvale clinics, so sending these clients farther away is creating barriers to their treatment. Though many clients at Sunnyvale can be identified as mild to moderate, they are maintaining this level of functioning due to RC interventions and support, along with the support of the treatment team at Sunnyvale. RCs provide valuable services, including providing food resources to residents of the county at risk of hunger and food scarcity, which I in fact did yesterday to a resident. RCs do home visits as therapists, and doctors don't go out in the community as they are tied to the clinic and stay in the office. At times, these interventions can prevent costly psychiatric rehospitalizations. And a doctor yesterday shared this statistics with me. Out of 2 doctors, there are 600 cases. They said 20% have a MORS under 6, and 3% of those 600 cases are severe and have a MORS of 4 or under. Thank you.
Good morning, everyone. Thank you for the opportunity to speak here today. My name is Natalie Rangel. I'm a mental health peer support worker at East Valley Behavioral Health, one of the primary care behavioral health clinics. And I'm here to talk about the importance of keeping mental health peer support worker services at the clinics. As you know, mental health peer support workers have lived experience with mental illness and recovery. And we provide a collaborative service with the clients as well as with the clinicians. Also, as you probably have heard, mental health peer support worker services are evidence-based practice, and it complements the services that the clinicians are able to give. Also, it reduces isolation for clients and allows them to expand their support network. Another important aspect is that it actually, so these services are shown to reduce expensive inpatient services by helping clients develop those skills and those coping mechanisms to not utilize expensive formal types of services. We provide peer-led groups such as tobacco cessation, positive living. We are RAP facilitator trained. We provide mindfulness meditation to clients and also depression peer support groups. So just wanted to emphasize the role that everybody in the clinics has. We work as a team, the rehab counselors, the mental health peer support workers, the therapists and the clinicians, psychiatrists. Everybody has an important role in the treatment process. And it's shown in the way that our clients, many of them are thriving. I think that it's important for them to have all the support that is necessary. And we do our hardest to provide that for them. Thank you.
Hi, good morning. My name is Logan Paulo. I'm the lead rehabilitation counselor at East Valley Behavioral Health. And basically just kind of want to reiterate what all my colleagues have said. I don't think I could say it much better than they have already, but that our services at the clinics that we all serve are vital. I've been with East Valley Behavioral Health since 2015. I've been with the county since 2011. And I couldn't be more prouder to work for an entity than the County of Santa Clara. And everybody that I work with there, from all of the staff who you just heard from, as well as all the doctors back at the clinic, couldn't be more engaged with their clients and dedicated to their care. And the first thing that came to our minds when we heard about this proposed change, the first thing was what's going to happen with the clients, what's going to happen with the doctors, what's going to happen to all the people in the community that have come to rely on us being here every day to support them. They know that they can pick up the phone and call us, and that we'll be there, that we'll bring them in for additional support in those types of things. And without that type of support, like my colleagues have said, you're at the risk for rehospitalization, you're at the risk for more acute services being provided to clients, which is in fact more costly to the county than it is to keep us there doing the good work that we do with the groups that we provide, the additional support, and everything that we do, the personal touches that the doctors and the therapists aren't able to do. So we just want to, get that message out there, and we'll continue to come and, reiterate our message, because we feel it's our civic duty to be able to speak on behalf of the clientele that we serve and the community as a whole of Santa Clara. So thank you for your time.
Why don't you hang on just a second, Scott? Renee, I know that we're not allowed to discuss this item because it's not listed on the agenda, but I didn't know if you had any direction that you'll be going as far as some of these issues that have been raised.
Yes, and good morning, Mr. Chair and Supervisors Committee. And we do owe you a full comprehensive report in terms of the reorganization, because I know it's a goal for us to integrate primary care and behavioral health in the ambulatory care settings, and obviously we need staff to remain there at the same time that we're trying to address some of the specialty mental health needs in terms of clinicians moving to the specialty system. So we'll probably need a full comprehensive detailed report, and we'll come back at a future date to do
Great,
that.
thank you. All right, Scott.
Thank you. Good morning, everyone. Scott Largent. Thank you for taking a look online of the videos that I put up on YouTube. After yesterday's meeting, when I was explaining to you guys what was happening on the side of the reentry center and how that woman was treated over there when they basically took her arm over the officer's head. We had the Department of Corrections right there, the Sheriff's Department right there, the San Jose Police Department right there. And you guys, that's about 10 feet from your reentry center. And that's how somebody is treated when they have a bad day at court. That video is online. I would hope maybe some of the supervisors could email it to some of the other people that are involved in behavioral health. And then I also put videos on there how I was treated when I was fighting for my property, how officers should not physically assault you, throw you out of the lobby. I mean, what I was going through was a mental health crisis. I had my property taken, so I was fighting for my property. I was panicking. I was worried it was being taken. I was never going to see it again. That woman there that day had a really bad day in court. And in that video, within the first minute, she says, I want to be put on a 5150 hold. She says it right away. They didn't do anything like that out there. They could have maybe slowed down traffic, maybe had somebody come from across the reentry center, kind of given that gal a pep talk. She was a sturdy gal. She was probably about 300, 350 pounds. When they lifted her arm up, the way the officer did it going over the top, I can't believe that's the way to handle somebody. She has knee problems, weight issues, all this other stuff. So it's very disgusting to see that happen. That video is getting a lot of views online. So are all the other ones that I've been emailing you guys. This is a good opportunity to see what somebody from the public's going through. I filmed everything for the last 3 years. I filmed it. I filmed interactions in the DA's office. I filmed everything in court. I filmed all my meetings with a lot of you, too. I wanted the people to understand what's happening and how people are ignoring everything. So I'm sure they're going to figure out a way to prosecute somebody with no record, but it's the right thing to do. Thank you.
Thank you. I believe, Michelle, that is all for under public comment. Welcome, Supervisor Simidian.
Thank you, Mr. Chairman. Sorry to be tardy.
That's all right. Just a couple things. I'd like to add item 13 to consent, and I'd like to move items 6 and 7 right after item 4. And I understand you have a recommendation on item 12.
I do, Mr. Chairman, and just I think the best course today would be to hold the item until our November meeting, ask that it comes back revised with a report on the potential for expanding intensive outpatient mental health services for adolescents or similar services at some similar level of intensity here in the county, as well as a timeline and a work plan for the expansion of those services. I think staff anticipates that. I'm seeing some nodding heads, and I think that'll get us to a more productive conversation more quickly.
Great, thank you.
So I'm happy to move the consent calendar with the addition of item 13, as you've indicated, and continuing item 12, as I've just indicated. And then I believe your request was to move items 6 and 7 immediately after item number 4, yes? Then so moved.
Great, and then that does take us to item 4, which is to approve the appointments and reappointments. Good morning.
Good morning, Board of Supervisors. My name is Yvonne Karanis. I'm the president-elect of the medical staff at Santa Clara Valley Medical Center, and I'm here in place of Dr. Tom Wensing today. I'm here to present the credentials report and answer any questions.
I don't believe we have any questions, but congratulations on your new post, and we look forward to working with you.
And just for the record, happy to approve the appointments and reappointments.
That's right. Send those onto the board for adoption. We now will move to item 6, and I don't know, Dr. Cody, if we're sort of combining 6 and 7, but both are under you. 6 being an update on the Public Health Department's Cut the Sugar, and item number 7 being an update on HIV/AIDS.
Right. Good morning, Supervisor Yeager, Supervisor Simidian. I think these two items will flow together nicely. Just a few general updates as part of my verbal report before we get started. In the last couple of weeks, I attended both the Big Cities Health Coalition meeting with big city leaders from across the country, as well as our local California Conference of Local Health Officers. And I want to tell you that each and every time I attend one of these meetings, I feel so grateful to be the health officer here in the county of Santa Clara. Our working context is much more favorable to preventing disease and promoting health, I'll say that. I did also want to let you know that our jurisdiction was one of the jurisdictions that did inspire the whole Big Cities Health Coalition to send a letter to the FDA Commissioner Gottlieb urging them to take regulatory action to ban flavors in e-cigarettes and vaping products. There's a few jurisdictions, including ours, that inspired this, and 20 of the 30 health officials did sign on to that letter. I think that you will be receiving a nice HIV update, so I won't say anything more about infectious diseases. Just one more comment as far as violence prevention. Our county leaders, both from the county and the community, are in Sacramento today with other leaders talking about the California Accountable Communities for Health and our violence prevention work in East San Jose. So without further ado, I would like to introduce Laura Jones and Teddy Daliga from our chronic disease group. They're going to share our Cut the Sugar campaign. So Laura, the floor is yours.
Good morning. Thank you. Again, my name is Laura Jones. Just before I get started, wanted to thank Supervisor Yeager for his sponsorship of the inventory item that led us here today, and Supervisor Simidian and the rest of the board support with that item. So thank you. And we'll just start going. So for this first slide, I know this committee is well versed on this issue, so I won't spend a lot of time, but just a quick reminder about why we care about this issue and why sugary drinks are so harmful and uniquely harmful to health. So some details about our campaign. We did complete a formal RFP process to select a vendor to help design and implement the campaign. Ultimately, we hired S. Groner Associates, who I'll call SGA from now on, to lead the effort. They're a firm from Long Beach, California. And to ensure that the campaign would resonate locally, it was built into the contract deliverables that the marketing firm would work with a local agency as a community consultant to help inform the campaign. Somos Mayfair was selected as that consultant, and we were really pleased and proud to have their input and guidance throughout the entire process. The campaign, of course, was also informed by focus groups and one-on-one interviews. And last piece here, we were pleased and proud to have First Five as a partner and sponsor for the campaign as well. So the campaign is focused on Latinx caregivers of young children, and that's basically a gender-neutral term for Latina caregivers. The campaign, it was launched in both English and Spanish, and while there is a county-wide presence of the campaign, we really emphasized our efforts in Gilroy, Morgan Hill, and San Jose, as most of our priority population lives in those places. And we really wanted people to see the ad and come away with an action step, so the campaign encourages residents to drink water and low-fat milk instead of sugary drinks. At last, here is an example of our campaign. The purpose of the ad is to really show, and hopefully people really feel the connection between sugary drinks and their associated health risks. You can see some sugary drink products and the health risks associated with those. And this campaign was launched in mid-August, and various pieces will run through the end of October. The campaign was disseminated through a number of channels, including transit. Hopefully you've seen some around town, both in bus trails and bus shelters, radio, online, and the online ads were specifically focused on sites that we know are visited by our priority population, and through social media like Facebook and Instagram as well. The formal evaluation for the campaign will begin next week, but I did want to report that the data that we have from the social media ads so far are very promising. In fact, the display ads are performing above the industry standards and well above in some cases, and the Spanish ads are performing particularly well. Okay, so our last slide, I did just want to point out in the picture next to Dr. Cody, this was at our media launch, and I want to draw your attention to Dr. Cody and the item next to her. We called those our inflatables. We have 3 of those. When the board asked us to complete this work, they asked us to have a boots on the ground presence for this campaign. We call this our guerrilla marketing, and Somos is bringing the inflatables to different high traffic events in the county to really connect with the community and bring the message right to people and make that face-to-face connection. So that concludes my presentation. Want to thank you again and happy to answer any questions.
Well, thank you for that. And obviously I was out there at Somos Mayfair for that event, and it was well attended, and we got good press from it, so thank you. A couple questions. One of them has to do with SB 1192. This is the bonding bill that was just signed, making milk and water and non-dairy milk the default beverage with kids' meals. I know that with our ordinance, where it's also the default is milk and water, and if you want a sugar drink, you have to pay for that separately. Do you know if that's how 1192 is working as well?
It's my understanding that it is not operating that way. Do you have a different, or do you? Maybe I'm wrong.
And maybe tied to that, does the state law supersede ours, and so we can't make it that you don't have the choice?
So my colleague Teddy is reminding me that in the state bill that you can substitute the drinks instead, so you wouldn't have to pay for them separately. And we are actually in discussions with county council about what we're going to do here locally if we were going to repeal our ordinance or what exactly we're going to do. So we're having those conversations now.
Yeah, and time and time again, it is often the case that we take action here at the county before it becomes state law. And Ms. Jones, you worked very hard on this ordinance that we had with the kids' meal, 5 years ago, if I had to guess, 5 or 6, maybe longer.
I do think and hope that Santa Clara County helped pave the way for the state, so we're very excited to see that happen.
And then are there next steps with this campaign? I think the money from the inventory item has probably been spent. Are we looking at continuing these type of campaigns or this type of public education?
So, do you want to
Do you want me to take that?
Sure.
So this campaign, as Laura mentioned, is focused on is targeted to these particular communities where there's higher rates of consumption of sugar-sweetened beverages. Once this campaign is done, we'll have the materials, but if we wanted to continue the campaign, we would require additional resources.
All right. Well, perhaps the person who succeeds me might undertake this as one of their projects. So, questions on item 6?
Would you like a motion to simply receive the report?
I would like a motion.
All right. Motion to receive.
Thank you. Now we move on to item number 7, which is to receive the annual report relating to HIV/AIDS.
Thank you, Supervisor Yeager. Dr. Sarah Lewis will make some comments about the written report that you have in your packet. Dr. Lewis is our STD HIV controller who's been with the county for about 2 years and has led the effort in helping to implement all the work to prevent HIV and STD and get the Getting to Zero effort organized and off the ground. And I would also like to mention that Dr. Lewis is something of a YouTube star from her STD screening video. So if you've not seen Dr. Lewis starring on YouTube, I encourage you to have a look.
I have not seen that, but
Well
I look forward to seeing it.
All right, Dr. Lewis.
Thank you, Dr. Cody. And thank you, Mr. Chairman, thank you, Supervisors Committee, and for the opportunity. I'm very proud to have a chance to present this report to all of you and highlight the really incredible work being done across the county in the prevention and treatment of HIV and AIDS. In May, I was in front of this committee talking about a very different picture with other sexually transmitted infections, where we're seeing rising rates and rising numbers of complications. But the picture here with HIV is a much more positive picture. We've actually seen a stabilization of the HIV epidemic in this county really for almost a decade now. In the number of new diagnoses, we've had roughly stable numbers for about 10 years. And the slight uptick we saw last year from the year before actually also comes with an increase in the percentage of late diagnoses, which may suggest that some of our efforts to increase testing has actually been successful in finding some people who've been living with HIV for quite some time and unaware of their diagnosis. We've also seen persistent improvement in life expectancy and improvement in every arm of the HIV treatment cascade, improvement in people aware of their diagnosis, linked to HIV care, and virologically suppressed. These advancements haven't been equally distributed, though. We do continue to see disproportionate impact of HIV upon LGBTQ communities, upon people of color, people experiencing poverty and homelessness. And so these are the greatest reminders to me that our work is far from done, that we don't just need to sustain the improvements we've had so far, but still have a lot more to do. And I think there are three main reasons that I'm able to report this positive epidemiology of HIV in the county. I think these are in part due to global scientific advancements, but then to the local collaboration we have here in the county, and then mostly to the sustained county commitment and prioritization of HIV and the communities affected by HIV. We see these scientific advancements really in the areas of the wide range of safer treatments now available, so that people diagnosed today with HIV have multiple options that can allow them to achieve virologic suppression and in fact have the same life expectancy as somebody not living with HIV. We also know those people, when they become virologically suppressed, have actually zero chance of transmitting HIV sexually to their partners, or what we refer to as undetectable equals untransmissible. And then finally, we have PrEP, a daily pill that is incredibly safe and incredibly effective at preventing HIV. But none of these advancements mean anything if we can't get them to the community, and that's what Santa Clara County has done so well. We actually have a long history of leveraging federal resources such as Ryan White funds and state funding to create wraparound services for people living with HIV and ensure they have everything they need to access treatment. And then also use additional funding to access testing and outreach and education. But there were gaps in this network, and that was what was picked up on by the county and championed by Supervisor Yeager, and prompted even stronger support in 2016 when the Board of Supervisors funded the Getting to Zero initiative, with the goals of zero new HIV infections, zero HIV-related deaths, and zero HIV-related stigma. And it's this additional booster into the gaps that we had in our existing systems that have allowed us to leverage those existing relationships we already had and really jumpstart very fast-paced progress in a number of areas in HIV prevention and care. And so going forward, with all of these moving parts of various funding streams and more than 50 collaborators between county departments and non-county community organizations, we have 5 main areas that we've been working to improve and that I report to you on our progress in today. Quality and usability of collected data, PrEP and PEP access, HIV and STD testing and integration of services, linkage and retention in HIV care, and HIV education and reduction of related stigma. And I think the continued work to be able to keep doing what we're doing and doing it well, to extend the benefits we've already seen and to make sure there's no backsliding, I think we'll need sustained and predictable resources for the work we do, clear communication, and continued commitment of all of the county players and community collaborators we have. and then unfettered modern data streams that allow us to keep measuring where we are with respect to the epidemic, how we're serving the communities we care for, and how the work we're doing is actually playing out for those communities. So with that, thank you for the opportunity to present the report to you, and I'd happy to take any questions.
Well, thank you. I do have a number of questions and comments, and after we delve into this a little bit, I'm going to have the people who are here that are working on this issue come forward and say their name and their position, so we can all thank them for the very hard work that they all do every day. I guess, and I'll call you Sarah if that's okay, Dr. Lewis. First off, you're doing a wonderful job. Dr. Cody, a great hire, a great position that we funded, and I know that you are making a huge difference in this, and we keep on sort of giving you more challenges that you have to work through, but I'm glad we've been able to give you the staff that is needed. I agree with everything that you said as far as the progress that has been made on many fronts, medical progress as well. But on a lot of these issues that I'll go into in a second, a lot of it comes down to the individual and his or her relationship with their clinic, their primary care physician, or the person that they have contact with. I think it's still a societal issue that that people are hesitant to talk about their sexual behavior. We know from the LGBTQ health assessment, many gay people don't tell their primary doc that they're gay, and so that important conversation never happens. And I think what we're all trying to do is work with certainly our own medical people as well as the private docs to make HIV testing just natural. Just don't even ask, just say, oh, and then we're including this. How well are we doing with sort of getting people tested? And we put a lot of resources into doing it, but I'm wondering if that message is being received particularly by the private docs.
That's a great question. I think to your first question, how well are we doing? I think we have some signals that we're doing better than we used to be. Some of the findings with the increased number of diagnoses, lower percentages of people unaware of their HIV diagnosis that we draw from a study at the state level, tells us that more testing is happening, and we know that it's happening more often in primary care settings and not just in isolated HIV testing opportunities, although those continue to be important. But a couple of things that we're doing, we know that there are still gaps exactly as you described, and we pick up on these gaps in a couple of key ways. One is by our novel provider detailing campaign, where we send expert health educators out into community clinics to talk to providers, either because we are aware that they're diagnosing HIV and STDs and may need additional resources, or we notice a gap that they're not diagnosing anything, and we know that that's likely suggesting a missed opportunity to care for their patients.
So you get that information, and then we'll send people out there to double check to make sure that
exactly
they need more information,
right,
or understand the importance.
Exactly. Whatever it is they need, whether it's practice conducting respectful and open sexual history taking, whether they need to understand new elements of how testing can be performed or paid for, or whether they need technology to assist them in things like pepper prep order sets that make this easier for the client as well as for the provider.
That's great. So that's sort of one step that's involved, and it's great that we're doing more mobile testing as well. Certainly, the easier you can make people get have the HIV test, the better off it is. So I'm glad we're seeing more of that. Then the next thing, of course, is for people who are negative to get them on Truvada if that would be appropriate for them. And I know that in the early days, I think even before you arrived, there was a lot of skepticism, a lot of ignorance, not much acceptance for Truvada, and so that then took a lot of one-on-one conversations with not only the patients, but also with the primary care doc. Could you talk about how that's doing, and are we making progress, and are doctors feeling more comfortable in prescribing Truvada, and then also trying to figure out how the insurance companies or the county might try to cover those costs.
Excellent question. So to the first part about how we're doing, we have a couple of signals that that uptake by providers, willingness to provide this service and do it well is improving. Some of that, again, comes from one-on-one feedback during our provider detailing sessions. Another is that the Please Prep Me website, where anyone can go and look up where's the nearest doctor who can offer me PrEP, has had increasing numbers of providers willing to list themselves as not just only willing to give PrEP, but maybe even an expert or somebody willing to recruit new clients to their care for the ability to access PrEP. At the same time, we do still hear reticence. We do still hear about clients who come to our PrEP navigation service who had a missed opportunity at another provider and described to us, it was recommended that PrEP wasn't going to help me or it may not be safe. And so we're able to then take that feedback through our PrEP navigation system, pass it on to either myself to do a provider training or a health educator to do outreach in that setting, and really respond directly to that concern that we're hearing. And then additionally, we're doing a wide number through the Getting to Zero PrEP Action Team, a wide number of trainings for providers, either in web versions, in person, going into doctors' offices, doing grand rounds to make sure we're changing minds with providers and showing them not only how safe and effective PrEP is, but how easy and rewarding it is to provide that kind of care for your clients.
So those are for the patients who test negative. Then we have the patients who test positive. And at that point, too, again, if somebody has health insurance, hopefully they'll be able to get on the antiretrovirals so they can have a suppressed virus. But what about people who don't have that access and trying to make sure that they understand the medicine that they need to take and how they have to take it on a regular basis, and trying to keep track of that they're in retention as far as their care?
So one of the things that is now a widespread practice nationally, but was done, some of the earliest practice was here in Santa Clara County, was the development of what we call the Positive Connections Team, who are linkage to care experts. So their job is the second somebody has a new HIV diagnosis, they're met one-to-one, sometimes even the day they receive their HIV test results, and really have their hand held through not only the emotional journey of understanding they have a new disease and figuring out what they need to remain healthy and keep their partners healthy, but understand all of the resources we have in the county. This is everything from housing support and case management, essentially free access to care. No one is ever denied access to HIV treatment because of cost reasons, legal support, housing support. So really wraparound services for somebody living with HIV to make that transition when they become diagnosed and understand that they have everything they need to be able to access medicine and stay on that medicine.
And I know that all these things that we've talked about takes a great deal of staff time.
What we do all day, every day.
What you do all day, and soon we'll actually see the faces of the people that are sort of doing this one-on-one work. But then the last part of all of this is public awareness of HIV, of getting to zero, of trying to reduce the stigma, and which is, of course, the whole idea behind the campaign for getting to zero. Could you talk a little bit about how effective we're being in that regards, and that I've also looked at the charts, the age group with the highest HIV infections are in that 20 to 29 year group. It seems like the other age groups much less, but that's still that target we have to hit. And every year you get a whole new cohort of people who become sexually active as they become older and get teenagers and sort of move on. So you almost have to start from the beginning with them because they just wouldn't have all that background. But if you could talk a little bit about how we're targeting younger people so that we can keep them not getting infected.
So that actually, I think that specific goal of making sure the general population are really aware of what HIV looks like today and all the opportunity that they have to prevent HIV or thrive if they have an HIV infection is some of what the Getting to Zero funding has been most powerful to do in a couple of novel ways. I think, for example, our social marketing outreach, which has been specifically talking about PrEP, but which has had a lot of collateral impact in terms of letting people know in general the changing HIV landscape, has been really impressive. And we actually received a report yesterday that while the report to you describes through the end of June how many, I think we had 13 million views of our latest PrEP social marketing campaign. We're actually at 45 million as of the end of the campaign last week. So we are really getting in the faces of the youth to let them know HIV has changed, and therefore the stigma related to it really should melt away as you understand you have the power to protect yourself and to thrive if you have the infection. We also need to start even younger than that 20 to 29 age group, and so a lot of the work we're doing is to improve sex ed in the county. And we're fortunate in California to have the California Healthy Youth Act, which requires that sex ed in public schools includes open, respectful conversations about people of all sexualities, of all genders, explicit information around PrEP and how effective and safe it is, and really the most up-to-date, scientifically accurate sexual health information. But a lot of schools didn't have the resources to make those changes to the most up-to-date and most beneficial curricula. And so again, we're doing work to bring curriculum to schools in the county and then to support parents' nights or school boards or administrators, whatever they need to make the change really happen in their schools. And I think that's where that really early education in what HIV means today is going to have the most impact as people leave school and become those 20 to 29-year-olds at risk.
Dr. Cody, do you have the resources that we need? Are there gaps that we need to fill as far as the overall program that we've initiated?
I think that with the support that we've had from the board to our program, that we've very effectively filled in the gaps. And most importantly, I think that we now have right people in right seats, and we're far more efficient. We also have fantastic partnerships with many of the people that are going to come and introduce themselves shortly. So I think for the moment, we're in good shape. Thank you so much.
Supervisor Smedian, any questions?
That being said, our numbers are essentially flat with minor fluctuations over the last 3 or 4 years, yes?
Are you referring to new HIV diagnoses?
I am, yes.
So in the report, I don't have the numbers as well as Sarah does, but they were up and then down and then up again. You have to tease out differences in reporting. So for example, the more aggressive we are to get people to test, the more cases that we're going to find. And so as Sarah mentioned, that even though we had more new HIV diagnoses in 2017, more of those were late diagnoses. In other words, people that we now have identified that we might not have before had we not increased screening, if that makes sense. So
it does. Let me ask the question that Supervisor Yeager asked, but in a slightly different way, which is, understanding that it's a complicated and challenging set of issues, that there's a sort of system-wide effort to try and address those challenges. What's the single most important thing we could do over the next 2 to 5 years to drive those numbers down? Lots of different things but so if you said, all right, and I'm hoping this isn't going to be the answer, or are those numbers not going to go down in spite of our best efforts? Because that's really what I'm trying to push.
So I'm too much of an optimist to say that we can't do better. We absolutely can, and when I say getting to zero, I literally mean 0 new infections. I think the most powerful thing we actually know we can do now that we understand that somebody living with HIV with an undetectable viral load who takes their medication every day has really no risk of sexual transmission, that making sure every person with HIV is not just in care and not just prescribed medications, but able to take them every day. Now, that's obviously much more complicated than it sounds because these are real human beings with complicated lives, and it's hard for me to take a vitamin every day. So I think thinking about sustaining and even deepening that comprehensive circle of care around anyone living with HIV so that they never have a question of losing access to their medication, even if their circumstances change, and that they have the other supports they need in their life to make sure that their doctor's appointment is not an insurmountable barrier to getting their medication. Fortunately, right now, we're in a setting where we have federal funding, we have some state funding that supports those systems. And so when I think about what resources we need, a lot of that depends on whether that federal or state landscape changes. But we've also instituted in the next several months a new data to care program that will allow us in real time to get names from the state of people who we don't know for sure are in care and go find those people, find out, are they really in care, and is there anything else they need? But if they're really not, what are they missing? And I think with that project getting up and running in the next couple of months, we'll have a better sense this time next year of the people who aren't virologically suppressed. What are we missing? What does that person need to never transmit HIV?
Thank you. Thank you, Mr. Chairman.
Thank you. You know, with so many of our programs that we create, we hire people, they go out there and do the work on a daily basis, but we actually don't often get to sort of see their faces and at least know their names. And so I asked Dr. Cody and Dr. Lewis if they could bring some of the people who work on this on a regular basis so they can come up and we can meet them. And I know she sent out the alert to the Getting to Zero Leadership, the HIV Commission, and the HIV program. And so if all of you don't mind, I'm going to have you just line up here and come up to the podium and say your name and say what your job title is so we get to learn a little bit more about who the people are that are doing this great work.
Mike Torres. I'm with the county's public health department, and I'm a health planner.
Carl Vitt. I'm with the HIV Commission.
Bob Reed. I'm with the HIV Commission. Thank you.
Vicky Contreras, Associate Management Analyst supporting the HIV Commission.
Robert Smart with the Health Trust, AIDS Services, and with the HIV Planning Commission.
Hi, I'm Marlene Bennett. I'm a member of the HIV Commission. I'm also a supervising attorney at the Law Foundation of Silicon Valley.
Hello, I'm Supriya Rao. I'm a senior analyst with the STD and HIV program, and I mainly do quality improvement work. Thank you.
Raj Gill with the Public Health Department, Health Program Specialist.
Sundar Thapalia. I'm one of the communicable disease investigators. I mostly do HIV surveillance.
I'm Elizabeth Frakes. I'm also a communicable disease investigator with the Public Health Department.
Jamina Hackett, Public Health. I'm a prevention program analyst.
Rodrigo Garcia, PrEP specialist with Public Health and Director of Colectivala.
My name is Candelario Franco. I'm the project manager for the Getting to Zero initiative, and I'm also serving on the HIV Commission.
Good morning. My name is Lori Osorio. I'm representing the UCSF and the AIDS Education and Training Center, and I'm also the Vice Chair of the HIV Planning Commission.
Well, thank you all. I'm really very proud of the work that we're doing. Yeah, I knew I was going to lose it, but it was it's so long ago, 1986, that it was the first time I ever spoke before the Board of Supervisors, I knew I was going to lose it, asking for funding, because at that point we had never funded any programs for HIV. Thank you for the Kleenex. And, you know, I just sometimes think I'm the luckiest person in the world that I've been able to work on this issue for basically the last 32 years. And from where we started, we're just panic in the streets, to really having a plan on how we can eradicate HIV. And I agree with you, I think we can get to zero. But it takes a lot of hard work, and I'm very just proud of what the county has done, what the public health has done, and really what all the people are doing on a day-to-day basis, because I think we'll get there. And with that, Supervisors meeting, we'll take a motion to approve.
So moved.
Thank you. So now we move back to item 5. This is the monthly report from the Director of the Health and Hospital System.
And once again, thank you, Mr. Chair Yeager, for your leadership over the years in terms of not only HIV and AIDS, but also all the public health issues. In this particular report, I also mentioned some of the trends that have been going on at the federal level. One immediate threat, which is the promulgation of a proposed rule on public charge. Again, this is proposed, but I know it's so important in our community. It has created a lot of confusion. It's beginning to have some of the impacts in terms of some of our clients and families. So I just wanted to bring that to the attention of the board. The other piece is an issue by Health Affairs. I think this is Supervisor Simitian, which asked us from the very beginning back in 2012 about the progress and how we're going to measure the effectiveness and that we made under national health reform. And so in this issue, they talked about California, some of the leading efforts, as well as gaps and challenges going forward. So I think I want to bring that to your attention. And then there's a very detailed report that Amy, Clara, and other staff did in terms of the legislative update of all the actions that have been taken by Governor Brown, as well as some of the vetoes that he's taken on some of the health legislation. And with that, I briefly conclude with one additional point, that this is the week when is the 10th anniversary of the Mental Health and Addiction Parity Law. And of course, we're going to be focusing quite a bit on mental health today and custody, as well as obviously Tony Tullis' report in terms of behavioral health integration. But I wanted to bring that to your attention that we still have a ways to go in terms of bringing parity in terms of mental health and addiction in our communities to the physical medical care side of the house. But I think it's notable in terms of some of the efforts that are going on here locally. So that concludes my report, unless there's any questions.
Thank you very much. Just a question, both for Mr. Santiago and perhaps as well for our county exec. The decrease in our Medi-Cal numbers is steady and significant.
Sure.
I'm looking at packet page 15 or page 5 of the 17-page report, and I sometimes joke in committee about charts and graphs that are designed to illuminate, but that sometimes, frankly, leave me struggling to grasp the trends. But on this one, it's pretty simple and straightforward. There's a sharp decline over a period of a great many months now. There's some hypothesis in the materials we've got that the drop in membership in Medi-Cal is, I'm going to read from the report, is likely the result of multiple factors, including a recent increase in the minimum wage, the high cost of living in Santa Clara County, and concerns about the public charge definition, all of which we've talked about. The question I have is, what's the financial implication for our organization? During the half dozen years that I've been back on the board, we've been restructuring the organization to respond to the Affordable Care Act, to the availability of resources that come with Medi-Cal patients. We're making a very important set of decisions here in the next few weeks, as Supervisor Yeager and my other colleagues know, with respect to a couple of hospitals. Some of this is predicated on patients showing up and having the right payer mix. What are the implications of that significant decrease in Medi-Cal, which shows no, there's really not much of a blip there. It shows no sign of abating. What does that mean for us financially?
Well, I can give you an overall view. The financing of our health system, the delivery system, has a lot of moving parts. And some of that funding that we would otherwise gain from a higher Medi-Cal population is currently being made up for with our Covered California program, which was a wise decision for the board to begin to participate in. But certainly there is concern about the dropping population, but it's a mixed concern. Part of it means that more people are making more self-sufficient, moving into the personal financial group where they are able to sign up for Covered California. and that's a positive. In terms of potential negatives, we do see a slight decline in our revenue. However, we are currently, Renee is, along with other healthcare leaders across the state, beginning the new negotiations for the next 1115 waiver. And since all counties and entities are experiencing the same reduction in Medi-Cal, I certainly expect that once we do get a waiver, it will take that into consideration and maximize the revenue that we bring down from the feds in other more creative ways than we currently do, mostly focused on performance metrics and focused on looking at different ways that we can maximize the positive experience for our clients. So short answer is right now we're getting some filling back up or some offset from Covered California and other insurance systems. We're also getting some more money from Family Health Plan, and in the medium run we will be involved in renegotiating the waiver. In the long run, it won't make much of a difference.
I wholeheartedly agree with, obviously, Dr. Smith, because if you recall, Medi-Cal or Medicaid nationally is counter-cyclical. So when you have an economy that's growing, you have full employment, et cetera, you normally tend to have a drop in enrollment. Although in this particular case, because of national health reform, Medicaid expansion, we had a surge in the number of enrollees and a huge drop of the uninsured. Of course, when the economy slows down and there's high unemployment, we tend to have high enrollments of Medi-Cal. So I think that's always something that we need to continuously monitor. And then the wise decision to be as part of Covered California, because that allows us to have a healthier payer mix and be able to open up other opportunities traditionally haven't been open to us.
Is there a point in the near future when enough time would have passed, additional time would have passed, that it would make sense to revisit this? Is it 3 to 6 months from now?
6 months would be good.
Great. But then if the chair is agreeable, I would move to agendize this particular item, and I'll describe it in just a moment for the clerk and for the record so that people know what it is I'm asking for. But I do think it would be helpful to come back in 6 months with an agendized item that considers and describes the impact, the financial impact of reduced Medi-Cal populations, if any. And the point's been made that may all work out, but it's just something I'd like to make sure we keep our eye on. Thank you.
All right, then we'll move on to 5B, which is a report from the Working Partnership USA.
Good morning, everyone. Supervisor Yeager, Supervisor Smidian. My name is Vaughn Villaverde, and I'm the new Associate Director of Health Policy for Working Partnerships, and I'll be working with Bob Brownstein on a lot of these healthcare stakeholder meetings. So on September 19th, we held an educational session for healthcare stakeholders. It was on how partnerships can improve healthcare for low-income and disadvantaged people in Santa Clara County. We hosted a panel, and actually Deputy County Executive Renee Santiago was on the panel, along with representatives from Santa Clara Family Health Plan, Uplift Family Services, Kaiser Permanente, the Healthier Kids Foundation, and the Community Services Agency of Mountain View and Los Altos were on the panel. It was very well attended, and attendees were very eager to discuss partnerships, both current and future. I'm also happy to report that we are in the final stages of planning for our next event, which is going to be next Thursday, October 18th, and it's going to be an event targeted at providers who are seeing signs of trauma and fear in immigrant children and families that they work with in light of the current immigration policies. So the themes are kind of pushing our, what is the nature of the problem, what can we do as a county to address this fear and this trauma, and then what are the resources that we need as a community of providers to accomplish this work. The response and the interest from the community has actually been very good, so much so that we've had to cap registration at 150 people, just because that's how much the venue will hold. So,
you know, it's a great project to work on, and I assume that these are issues that would exist in multiple cities, certainly in California and across the nation. Do we know of that type of work being done elsewhere that we can learn from or replicate?
I personally do not know of any initiatives in the Bay Area of counties kind of taking up this issue. What we're really targeting is what can we do on a local level to help address this, even if these immigrant families and children are not necessarily in danger of immediate deportation. There is a lot of fear. There are a lot of children in schools who see things on the news, and so we really want to focus on what we can do as a county to address this.
Well, we'll look forward to getting a report from you once that program gets underway.
Of course.
Thank you.
We move on to item 5C, which is to receive report from Behavioral Health Services relating to organizational activities.
Good morning.
Good morning, Tony.
I'll hit a couple of highlights and then just to answer any questions that you might have. I think one thing I want to highlight, and I know that my team is here and also watching, we were able to complete all provider contracts with changes in the language and the up to 12% increase. Those were all completed September 28th.
Congratulations.
And I think that's a significant
Probably
amount of work for
probably
my
a
team.
lot of happy people out there.
A lot of happy people and a lot of happy staff. So I want to highlight that. The other thing that we're spending a lot of time on, you have approved the MHSA 3-year plan, and we're releasing 2 RFPs this month. And the 2 big ones are coming out next month. So there's a lot of procurement processes underway to expand both the less intensive outreach and engagement services as well as the intensive services that the county needs. I think the other thing that I want to highlight is that there's a lot in here, as you know. The Sobering Center continues to see more people. I know that's been an area of concern for the board members. And we're just waiting for San Jose to finalize the agreement with the county, and I think that will be a go.
Yeah, it seems like that's finally getting close.
It's getting close. It's getting very close. And I think the last thing I want to share with you, and then answer any questions, I don't want to minimize the work of our staff. The MHSA, we're launching the MHSA 1-year update, and we'll be bringing that to the board much earlier this year. There'll be ample time to review what we put into the plan at your request and at Supervisor Simitian's request. So, are there questions? Do you have any questions?
You know, we have one public comment on this. Scott Largent. Scott, are you with us?
I don't see him.
Maybe he just stepped out. I don't have any other questions, so I think
and I think
we're
he's
good.
Fine.
I think
okay.
I think we're good.
All right. Thanks.
Then we'll move on to item D, which is receive report from Custody Health regarding custody health services data.
Good morning, Supervisor Yeager. It's Matt Guerrier. I'm the Executive Director for Custody Health Service, and I'm here with Dr. Nathaniel Woods, our Director for Custody Behavioral Health. And we'll present the report. Just as an aside, if you'd like us just to answer questions, I wanted to offer that to you rather than go through the report, or we can go through the report.
Why don't you go through the report, if you will?
Terrific. What you see is we're doing our comparison between where we were and where we are now. We started a few years ago in what is known as an episodic care system. This is really a reactive system. It just really treats what the issues are in front that are brought forward to the caregivers. It really is not the best system, but it was the system that was in place at the time. We have now moved to what's known as a patient-centered system of care, where the patient is also part of the involvement in the system itself. It's much more of a global look at the patient and the treatment. It concerns not only the medications and the medical and mental health treatments, but it also looks at behavior modification, diet, and participation that way, and the education that goes along with that. So it's a much more proactive care system, which is our current system of design and where we're going with it. Just as a little comparison between where we were in 2015 and where we've gone to, so I just talked about the episodic care model versus the patient-centered care model. What's impressive to me in going through these numbers is we started with about 1.5 psychiatrists for a population that was around 4,000 at the time. Now we're sitting around 3,200 to 3,500 inmates, and we have 9.5 coded psychiatrists. We are using transitional behavioral health psychiatrists to give us more coverage in booking for 24 hours a day, 7 days a week, as well as the coverage in 8A. No behavioral health teams, now we're up to 10, 9 solid ones, and we're in the process of filling that 10th team at this point. Crisis intervention teams, you'll notice that the number goes down, but that's because we've with the onset of the design that Dr. Ho and now Dr. Woods is following through with, we went from 20 crisis intervention folks down to 14, but we've changed with the behavioral health teams have changed from a matter of 8 clinicians up to 29 now. So the staff has increased up to 280 for total staff for custody health service. This is just, I know some of the supervisors had been asking about the process for healthcare booking. We have our intake screening, and every inmate that comes in is registered as a patient in our system, whether they get services or not. So that gives us an opportunity to provide the services with no delay. The folks that come in are assessed for both medical and behavioral issues. Which if there's any, in the initial screening, if any of it triggers further assessment, then they're sent for either a medical or psychiatric assessment. And as I mentioned in the last slide, we do have psychiatric care 24/7 in booking. So we do have a psychiatrist on staff down there as well as a mental health providers to do the further assessments down in booking. And then those are some of the housing options as to where folks end up. This is just, again, it's sort of a flow through our system about custody health service flows. So intakes, booking, we've talked about it before, initial screening that leads to a 2-tier assessment system and a behavioral health assessment that includes a psychiatric assessment in there if folks need those services. We also now look at what we do on the inside to try to provide the services while they are patients inside our system and have either a medical or mental health need. And then what treatments, what medications, we're measuring all of that at this point. And then I think Supervisor Simidian has brought it up before, but what are we doing for the discharge? We have a series there. This is behavioral health services. We do have a full range of services throughout the jail stay. Of course, 8A and administrative housing is our most intense. We start with intake, where we do screening for whether somebody requires any mental health services. That leads to different levels of acuity. We can provide services at an outpatient level. If folks have more of a need, they go up to special management units, and then, of course, the most intense services are provided on the 8th floor. Just so folks understand, HealthLink, we looked at putting in the Epic HealthLink system. It is in place now. It's been operating now for a little over a year and a half, almost 2 years, and some of the things that are unique about it, we are the only custody health system, as far as I can tell, in the world that has Epic in place using the hospital model as the care system, as the foundation. We were the first ones to bring that to market. Also, the interesting part is we're the largest opening of a hospital in the Epic system worldwide, because within a weekend period, we moved 3,600 patients into the system in our quote-unquote hospital. So it's kind of a unique place to be, and it puts us on the cutting edge of providing care for the inmates. The next set of slides I'll have Dr. Woods present.
So we looked at data, I guess, regarding screening and intake on a monthly basis. So for September of 2017, we did an intake of 3,359, of which 2,724 was conducted at Elmwood and 635 was conducted at San Pedro Main Jail. From that, for gender measures, males were measured at 2,869 and females at 490. When we look at custody behavioral health numbers in more detail, the 359 people were screened at intake for initial medical and behavioral health screening for additional recommendations for housing as well as assessments. 790 people were seen by psychiatry and booking. That includes all behavioral services for those individuals who are more stable or at the highest acuity level. 305 were admitted to 8A and administrative housing from booking to be provided the most intensive behavioral health services. And then we also have actually a different number of 4,920 behavioral health evaluations that were completed. From that, 1,471 new behavioral health cases were identified at all acuity levels. 480 psychiatric evaluations completed for patients on 8A with the most intensive behavioral services. When we're looking at measurements of efficiency regarding psychiatric consults completed, we've managed to decrease time from 3.5 hours to less than 2 hours for the highest acuity patients. Consult time is reduced just under 2 hours for men and women on 8A with the behavioral health team included. 8A patients were assessed with less than 1 hour.
So there had been some reference in the Sheriff's Office report about grievances that had to do in their system that's known as ACES. That's the new grievance system for the Sheriff's Office. We have then taken a look at those numbers that were produced. There was 714 grievances that were noted. What that equals is about 119 a month because it was over a 6-month period. We're now down to about 98 grievances that we've received in the month of August, and we are looking at this to try to we've assigned the managers over the areas that the grievances have to do with to try to get these numbers down even further and assess what the issues are and then try to have have a plan in place to resolve the grievances with the inmates that are brought through. So this is separate from the white card system that we have in place as well. On the next slide here, you can see that we have about, through the white card system, which is a system for requesting medical services, we have about 120 white cards that we get per day. That's still a solid number. That's about a 20% increase from last year, as opposed to the ACES system is about 5 grievances per day that we get through that system. So we do still process most of our things through the white card system. And you can see on the left there in the blue boxes the methods at which we can get notified from folks, including family members and outside providers, to know what the issues are and then come up with a plan to resolve those.
And just for a second, Matt, on that one, I know that in the past there was quite a backlog in responding to the white cards. Are we doing better at responding to these issues in a timely manner?
Yes, sir. Yeah, we have a log system now in place to look at when they came in, so we have a time clock going on them. We've put this into the HealthLink system so that we can monitor it, and the system will automatically add a date and time to it. And then we try to do at least a one-on-one discussion with the inmate over whatever the white card request was within a 24 to 48-hour period.
Great.
We're still refining that. We can get better and better at it. My goal is to try to get us to the 24 to 48 hours solid every time.
That's great progress. Thank you.
Early improvements. So this is just a focus of what we're looking at for custody health, and just some things to note. Have an average length of stay on 8A it's decreased by about 20% over the last year that we can measure, but the volume's actually increased by about 16%. So what that tells me from an operational perspective is we're actually doing well. We actually met with the 8A staff this morning to try to come up with even more efficient systems to try to put in place. And then just some notes on things that we've added, the behavioral health team, of course, the initial screenings that we've talked about, and then all of this is leading to being able to analyze the systems of care that are provided and provide better and better care to the inmate patient population that we have. And with that, that's our report. If you have any questions, we're glad to answer.
Yeah, just a couple quick ones. But first, welcome, Dr. Woods. Nice to have you here at the county. So, I was wondering do we have much data on the health services when inmates are released and whether they're connected to primary care or whether they are able to get a medical appointment within, let's say, 6 months of being released?
I don't have the data in front of me, but I do know that we are, when we do make the appointments with inside the system, that we have followed through, and I probably need about another 6 months or so to get you a solid set of reports out of there. But we do know that now, if we have made an appointment that would have been, the inmate patient would have been seen inside the jail for, say, to Dr. Cherney's folks or to the mental health side, that if the person is released in that time where the appointment would have come up next, we try to make that appointment in the system itself so that continues the care across the spectrum.
Great. And then how well are we doing at managing chronic diseases? In particular, I'm thinking about diabetes. Once we've diagnosed it, what kind of care after someone is released?
So we do follow that inside the jail for the management that we do inside the walls of Custody Health Service. What we're doing now is we're talking to the folks over at Valley Medical Center to make sure that as we look at the management reports that we do for our side, that they match up, and so we can look at the chronic care conditions across the spectrum, so that whatever Paul's folks are doing over at the hospital and then inside the ambulatory clinic is also the same type of things that we're measuring now. And since we're in a catch-up mode to the hospital and the ambulatory side already having produced those reports, we want to make sure that we're vetted correctly so that when we look at this, we look at it at the whole spectrum rather than us being an outlier.
And how are we doing with training correctional officers in mental health?
So I had that question posed, and I was trying to get you the numbers here before I had the report today, but I don't have the specific numbers. But we do a training. There's a set of trainings that go on for both de-escalation techniques. There's also the multidisciplinary officers that are there that we do quite a bit of work with. They're providing both input to some of the behavioral health teams, especially in the more intense areas like 8A and the administrative housing areas. To have the plan be a multidisciplinary plan across both the healthcare, mental health, medical care, mental health care, and the corrections side, so that we're all on the same page with how to approach the patients that have the most.
And is a lot of that training done, when you had the list of psychiatrists and mental health workers, is that mainly done sort of in-house as you will, or do you contact behavioral health to get additional resources?
We've used
training?
One of the psychologists to go goes to the training with the training folks at on the sheriff's side to coordinate things like suicide risk assessment from the correctional side perspective. We're going to put in place soon training to do assessment for stroke or seizures. So we're in the process of working with the Sheriff's Department really closely to try to get a coordination between those two sides.
Thank you. Supervisor Smedian, any questions? Then thank you. And then Michelle, so we'll approve all of 5A, B, C, and D and send it on its way. We now move to item 8, which is receive a report from Valley Medical Center relating to adult adolescent sexual assault forensic exam. And I know I have a number of cards on this. I think what we'll do is get a report, then ask people to come and speak if they would like, and then questions from the committee.
Thank you, Supervisor Yeager, Supervisor Simitian. At this time, I'd like to introduce a few staff members. As they are getting seated, this is a board referral directing staff to report back to this committee about the current status of the program and, of course, the future of the program. And just as in many instances, the county is relied upon for critical services to the community. This sexual assault forensic exam program is one of those programs that is critical to our residents of this county. So at this time, I'd like to introduce Andrea Brolini, who is the nurse executive over emergency and critical care services, Kim Walker, who is the program director of the SAFE program, and Dr. Sharon Koo, who is the medical director of the SAFE program.
morning. Thank you very much, Supervisor Yeager and Smidian. My name is Kim Walker. I am the program coordinator for the adult adolescent team in Santa Clara County. I have been a sexual assault nurse examiner since 2004, and I've been in this position since 2016. The adult adolescent program has been in place since 1987. We see patients who are 12 years and older for acute exams, which is within 10 days of an assault. We are part of the larger SART committee within the county that is codified in the penal code. The county SART is comprised of the DA's office, the crime lab, the forensic exam team, law enforcement, and advocacy. So we are part of that, and the SART is different than the SAFE program. We also have the Center for Child Protection, or the pediatric SAFE program. They see patients 11 and younger. They are separate from us, and this report is going to focus on the adult adolescent program. So for the number of exams that we see, we have a graph that shows since 2015, we've had year-over-year increase, as much as 9 to 20%. We are on target this year to reach well over 400 cases, which will be the first time in our existence that we've done so. If we meet our goal, we will have achieved about 28% increase over last year. So our current staffing, we have our coordinator and our director. We also have 13 trained sexual assault forensic examiners. For the adult program, those are registered nurses. We are available 24/7 to respond to any patients that come in requesting an exam. And we currently provide those exams primarily at the main campus on Valley Medical Center. We potentially have future exam sites that we're looking at that we can respond to in both the north and south counties of Santa Clara. We also potentially are looking at a site in Santa Cruz County. Primarily, patients are brought to us through law enforcement. They arrive at Valley Medical Center with law enforcement. This is a chart of the various agencies within the county that we respond for. You can see at the bottom that San Jose and Santa Clara sheriffs are our largest users. We also see quite a few agencies outside of the county. The sheriff generally responds for those by kind of a proxy, but we also have seen a lot of Santa Cruz County staff, and then we will see as far away as San Luis Obispo or San Francisco, other agencies that we will respond for. Because of the increases in numbers with our current staffing and our current program structure, we have run into some challenges and barriers. With sexual assault forensic examiners, there are specialized training that's required. This is in addition to what they already do as nurses. So this is added specialized training. There is a 40-hour didactic class that's required, and then there are additional testing that we have to have them go through with Women's Health, and then certainly with our program to make sure they have enough exam time. We are working right now to develop a staffing model that will accommodate the extension and our ability to be able to respond to additional sites and be able to compensate the nurses at a fair market rate. We also have issues with the fact that a lot of our patients require medical clearance when they come to us. They might have been strangled in the course of an exam, or they might have head trauma, additional injury, chronic illness that may have been exacerbated by the assault that needs to be seen medically. We have some limitations right now in that our primary site at Valley Medical is the only place that we can provide those exams. The technology also and the equipment that's required, because of the advances in criminalists and the need to be able to process evidence correctly, we need to be able to collect evidence correctly. So the technology advances, and we need to make sure that we have this equipment available. It's not necessarily inexpensive, and we need to be able to replicate that in each location or be able to provide it nearby so that we can pick it up on the way to that location. Current management structure, we are looking at that right now to be able to return to the Board of Supervisors with a proposal to address staffing. In the meantime, our recommendation is that we address staffing right now so that we can look at expansion to respond to the additional sites, to include a nurse manager, additional nurse coordinator, clerical support, data management support, and a staff developer to help with additional training. And we believe this management structure needs to be in place prior to the expansion being able to occur. We also need additional forensic examiners. We right now have 13. We will have 15 shortly, but we need an additional 4 in order to be able to provide that 24/7 coverage at those additional sites. So the timeline for expansion in the North County, we are currently collaborating with Stanford University to provide weekend coverage. We will utilize the Stanford Emergency Department for medical needs for the patients. And we have a projected start of early 2019. In the South County, we have an exam room ready at the Valley Health Center Gilroy Clinic. We need to establish an MOU or an agreement with the local hospital there so that we can provide emergency medical exams at that location. And the goal is to open nights and weekends in early 2019. We also have been working with Santa Cruz. As of last year, they had to fold their program due to staffing issues and challenges there. We've been seeing their patients for the last year, but we want to make sure that we have an opportunity to help them, if we can, to open up their clinic as well in 2019. There are some future program services that we would be able to provide. First off, one of the gaps that we've found is that we need to be able to mobile response to outside hospitals. There are patients that are inpatient that can't be transferred to us to be able to do an exam at VMC. So we would be able to go to their location for their inpatient population. Someone who might be high risk in labor and delivery who can't be transferred to us. We would be able to respond there. There also are potential additional populations, additional victims of crime that could benefit from an exam similar to ours for the skills that we provide. That's in the future, but there's been a lot of emerging best practice, especially in San Diego, with respect to strangulation exams, domestic violence exams. The other thing we spend a lot of time doing is outreach, whether it's to help train our partners, law enforcement. We work a lot with advocates, community outreach. We go to the colleges. We spend a lot of time with training to make sure that the community knows where and how to get exams when they're in need. So in May, Supervisor Chavez had requested a little bit of additional information regarding the pediatric team and some of the differences. Again, they see patients 11 and younger for the acute exams within 72 hours. They also do non-acute exams or late disclosure exams for patients who are outside of the acute timeframes, the 72 hours for pediatric and the 10 days for adult. Approximately 90% of their patients are provided with a non-acute exam, and those are done primarily at VMC. There was a question about the types of interviews. There are 2 types of interviews, and they get confused. The medical interview is what's done by the examiner in order to be able to determine what kind of exam is going to be needed. The forensic interview or multidisciplinary interview, those are done usually with many of the partners there. The DA might be there, law enforcement might be there, and that's so that the child only has to provide this story one time with all of the necessary people present. There has been some question about whether or not an interview center could be located downtown at the Spark Clinic. That has been looked at, but the only space available there is a playroom that's not ideally set up for that purpose. They're in talks right now, they being the pediatric team, to hopefully co-locate some of the services for abused and foster children across the street from Spark, so that while they might not be at Spark, they would be located next to it. So it would benefit the patients to not have to travel great distances for the various exams or needs. So that is it. Are there any questions?
Yes, thank you. I think we'll go ahead and hear from the public and then questions from the committee. So I'm going to read your names, and you can just please come up, and you can speak in any order. It doesn't have to be in the order that I read your name. Jenny Richardson, Susan Ellenberg, Tanis Crosby, Erica Elliott, Rosa, and then I can't quite pronounce your last name, Rosa, Brianna Leon, Lynn Tran Fong, and Catherine Williams. So please, forward. Thank you. And everyone will have 2 minutes.
Thank you very much, Supervisors Simidian and Yeager, and thank you to all of the staff who has prepared this report. I'm really pleased to see that it's being considered. It's by now been made very clear that our large county needs more than one location to maintain the resources and capability to conduct these really vital and difficult examinations. As we know, victims of sexual assault face many barriers to reporting the crimes that were committed against them. Access to the exam itself should not be a barrier, whether because of distance or wait time. The report that includes a preliminary timeline to be opened for a SAFE program to be opened in North County is a modest start. I want to draw attention and ask some questions about factors that I think should be considered when accepting this report or requesting additional information. My first question is, will the initial program be open to all North County residents or just to individuals associated with Stanford University? If it's the latter, this would to me suggest a great inequity in access to services and should be amended at the very outset to make it clear that access is available to anyone who needs the services. Second, outreach services are listed under future program structure with no associated dates at this point. And I think it would be irresponsible to begin to offer the medical exams without also having in place education on trauma-informed care regarding assault, rape, trauma syndrome, and access to services. And third, certainly there are details that need to be worked out regarding infrastructure and staffing support before expansion can occur, but the report currently doesn't include any SMART goals, and I'm concerned that the report may lack some of the urgency with which the need for a North County Safe Center should be met. I want to encourage you to direct staff to clarify that even an initial pilot program should be made available to anyone who needs such an exam, regardless of their affiliation with Stanford, and to request a more specific report that details an actionable plan. Thank you very much.
Hi, my name is Jenny Richardson. I am a board member for Women's March Bay Area, and I lead their outreach. I was also the director of field operations for the recall of Judge Persky, and I'm currently on the board of Enough is Enough Voter Project, which is a political action committee that holds elected officials accountable for both personal conduct and policy decisions. So I've been involved with a lot of the grassroots organizing around this issue. And we are concerned about special treatment for Stanford victims and the expansion into North County in a way that privileges women who are often already quite privileged. It should not matter where the assault has occurred. We want to ensure that everyone has access to the same services. So we do not support this pilot program unless it is open to everyone, regardless of where the assault occurred, has the same high-quality staffing, and is able to provide a YWCA rape crisis advocate within the required period of time, and not just a Stanford counselor, which is required by state law. Sexual assault survivors have the right to a rape crisis advocate during medical evidentiary exams. Currently, YWCA and Community Solutions are the only two rape crisis centers permitted to dispatch sexual assault advocates to SARTs at Valley Medical Center. They're receiving no funding for the sexual assault services provided, and they're required to provide 24-hour coverage to dispatch these advocates and arrive within 30 minutes, and covering a geographic range from San Jose to North County. So it is critical that this program is implemented and properly funded. Given the current political environment, there's been an increase in calls to these to the YWCA crisis line, and I ask that you please properly implement this program under the guidance of the YWCA and fully fund it. Thank you.
Good morning. My name is Tanis Crosby. I serve as CEO YWCA Silicon Valley. We are the only we are the only rape crisis center from San Jose to Palo Alto. We've provided some additional information to the staff report that we will leave with you, but we really want to highlight the role of rape crisis centers. As you heard, and we fully support what the prior two speakers shared, victims of sexual assault have the legal right to receive support services and medical accompaniment and we have the mandate to deliver those services in this specific geographic area. Currently, we receive $0 from the county to deliver these important services. We work in close partnership with Kim and the team, and we really want to highlight the critical role that rape crisis centers play in this continuum of service. It's not just critical, it is a mandate that is legally required by our state. And expanding the services without thinking about the community resources is providing us with an unfunded mandate. An unfunded mandate to expand services, to consider mobile advocacy services, to be there, to be present within 30 minutes without the resources to do so. We are resourcing expansion. We are resourcing rape kits within 30 days. That is excellent progress. And in the hometown of Dr. Blasey Ford, we think we can do more. We think we can lead the nation in making sure that rape survivors have access to the healing and support service, not just that they deserve or are legally entitled to, but the support services that are needed to ensure the kind of quality care. My colleagues will speak more about the impact of their work. They are incredible staff members who are doing incredible work under strain and increased demand that we haven't ever seen before. Thank you for your time.
Good morning. My name is Lynn Tran-Fong. I am the Crisis Intervention Coordinator for YWCA Silicon Valley. I chair the county's SART committee alongside Kim Walker, who presented the report to you today. This committee includes representatives from all agencies that are involved when a survivor makes a report or come forward seeking help. The SART committee meets to ensure consistency and collaborative responses and to make sure that we are addressing the gaps in systems that might get in the way of survivors getting help. We are in the final stage of crafting our county's first ever sexual assault response protocol, which will act as a countywide MOU among all partners that when a survivor comes forward, this is how our county will respond. Partly due to the information that has been disseminated from this committee, survivors in this county are feeling empowered to come forward and exercise their rights and access their options. When I first started as an advocate with YWCA, we averaged around 2 to 3 responses per week. Now we're seeing the upward to 10 responses a week. Last weekend, we had 5 responses over the course of one weekend. Weekend before that, it was 6 responses, and the weekend before that was 8. This is not a sudden surge. This is a consistent increase due to the Me Too movement, due to proper dissemination of information that is coming out of our committee, which leads me to come here today to ask for financial support. Currently, we have no money from the county funding sexual assault. When YWCA wanted to form the SART committee, we actually had to go and petition for state funding to make sure that we locally are getting consistent services to our survivors. On the advocacy level, we have 8 advocates in total responding to sexual assault forensic exams. We need more funding, we need more assistance, and we need the county to let survivors know that when they come forward, we stand with them. We don't stand with them just in name, we don't just stand with them in words, we stand with them financially. We're funding the infrastructure that will help them speak their truth, and we're funding the infrastructure to support them and get the healing that they need. Thank you.
Good morning, everyone. My name is Brianna Leon, and I am currently a community support advocate with the YWCA. To further emphasize what my colleague just mentioned, I provide survivor-centered, trauma-informed services to survivors of domestic violence and sexual assault. I first started working with the YWCA, I had very few on-call shifts. But with the current climate of the country, more survivors are becoming bold and coming forth with their stories. The volume of SARTs has increased a considerable amount, and by default has increased the number of 24-hour on-call shifts advocates have inherited. Upon arrival at any police station, detective interview, and Valley Medical Center, I am not burdened. Instead, I have become overwhelmed. In addition to the caseload that fluctuates between 35 to 45 cases, I am expected to be present at SARTs that can take up to 8 to 10 hours. On numerous occasions, I show up to Valley Medical and witness clients that are in distress, cannot sit still, streams of tears, bruised, and clothed in garment that has been tainted by a person that never received consent. Some survivors are 5150, homeless, have not been medically cleared. I have shown up to the emergency room with a woman laying on a stretcher, curled up with her daughter beside her. This was my third start of the night, and the nurse on call asked me to enter the survivor's room where she was sleeping and introduce service to move forward and begin the exam. I did not want to startle her and wake her, but I did, and she turned to me. Her right eye was dark black and swelled shut. She was kind, but I kept thinking, how is it that we both ended up here in the ER on this night and at this time? I knew her journey to healing was just beginning, and I had a duty to support her the best way I could. I am here today because advocates are a vital component to the entire SART process with the support that we could provide. And today we are asking for support to staff and provide equitable resources through the SART clinic and program. Thank you.
Hello, my name is Rosa Revuelta. I have been an advocate who's worked with survivors since 2005. I am here as a community member and someone who's worked with law enforcement, district attorneys, and the forensic nurse examiners on sexual assault cases here in Santa Clara County. I've sat and held the hand of hundreds of survivors, men, women, and children, as I've been there as an advocate as they've gone through the forensic medical exam at a SART. As a survivor myself, I had a sexual assault advocate sit with me as I shared the most painful details of my assault. And having someone there, I can't even begin to explain how important it is and how much it matters. There is a rape crisis advocate who's guiding, supporting, providing options to survivors, and this is by law at every single SART. Having a rape crisis advocate makes a huge difference. They provide the support no one else can. And since right now there's no money for rape crisis centers that is funded by the county for the work that they do, any expansion of services within the SART program at BMC will also require additional investments in the services that the YWCA and Community Solutions are doing, and this is because they need to. I support the creation of a North County clinic because the need is there. It's very difficult for someone to come all the way to this area, or for also the South County for someone to come from all the areas that are coming all the way here. And I support the additional funding and resources to the work that the clinic is doing. My one other concern is around the North County not being accessible to all of the different members of that community. As a community, we should expect no less is provided to survivors. Survivors deserve to be believed, supported, and that we invest in them and we invest in the services that are providing support to them. Thank you.
Hi, my name is Catherine Williams, and I'm here as a concerned citizen who's concerned about this issue. I support the ask of additional funding to resource the work of the SART program. However, I think it's important to note that by law, for every exam that is conducted, a sexual assault advocate is required to be called out. Any expansion of services within the SART program at Valley Medical Center will require an additional investment to YWCA and Community Solutions for the work required by law from sexual assault advocates. Regarding the North County pilot program, I have serious concerns that the location of the program will not provide equitable service access for sexual assault survivors to receive services. Every survivor in North County should be able to access services, and we want to create a pilot program that does not segregate survivors based on educational attainment. Thank you very much.
Good morning, my name is Erica Elliott. I'm the Sexual Assault Program Manager at Community Solutions, and I oversee our rape crisis services in South Santa Clara County and in San Benito County. So both South Santa Clara County and San Benito County both utilize the Santa Clara County SART at VMC. In 2009, our work group raised funds through our law enforcement officers to purchase equipment to open up a satellite office in the Gilroy Valley Health Center, which was running for a couple of years. Unfortunately, our nurse left in 2015. Who was our on-call nurse for South County. She was one of the only SART nurses that lived down there as well and was able to respond, which made effective and efficient responses for our officers and to conduct for our SART exams. After she left, we've been without a nurse for the last 3.5 years, so all of our clients have to travel 45 minutes to an hour and a half to receive a SART exam at different times of day or night. SART exams can take 6 hours, like as short as 4.5 hours, up to 8 hours, sometimes longer, to complete. So people are driving in addition to coming up to the exam, also having to drive through traffic or other lanes, which can also impact their success. The work that the sexual assault examiners do is very important. They're great at their jobs. They're very trauma-informed. They make sure that they always, they're trained, efficient, and really responsive to client needs. So I really want to encourage this committee to also support the expansion of them, hiring the nursing staffs they need to really effectively do their jobs, but also take into consideration all the other speakers that have spoken. And as we expand county services, to also expand to additionally support clients by providing the services that through advocacy and other support services in that way. Thank you very much.
Thank you, and thank you all for coming, and certainly thank you for the great work that you do. You're dealing with survivors with probably the most traumatic experience of their lives, and just to have someone, to have the services, but also to have somebody nearby to be able to help walk them through it, I know means a great deal, and we just appreciate it. I know we have any number of questions that were raised. I know Supervisor Smidian has been working on this as all of the board has. But Kim, I didn't know if you wanted to, rather than asking you a whole bunch of individual questions, if you had some comments about the issues that were raised, particularly about any crimes that are happening in the Palo Alto Mountain View area separate from the Stanford campus, and also about the funding issue, particularly as it pertains to the YWCA.
Thank you. Yes, with regard to the pilot clinic, we were approached by Stanford with issues of students not being able to leave the campus. But what we had told them is that we can't just provide care for the students. What we could do is consider a pilot clinic where we would respond to anybody within the jurisdiction of the Stanford DPS, Department of Public Safety. That means anybody within their jurisdiction, so it's not just students. But what we felt this would do is give us an opportunity to expand incrementally so that we could get the staff and move towards a 24/7 North County clinic. The other issue was that we didn't have an identified space for a clinic in the North County. It's much easier in South County because we have a clinic in Gilroy, but we don't have a clinic or space in the North County. So we would need to possibly talk to Stanford Hospital or talk to other partners up there and maybe lease space. But that was where we were looking just to do an incremental pilot project.
And I couldn't tell from the report whether it was going to be at Stanford Hospital or the student clinic.
It would be at a location within the Stanford University, but it would be a health center. So we would have the opportunity to still provide medical care or have patients get medical care through Stanford Hospital. The Stanford Hospital also had some issues with construction. So they were busy with that, and there would be a delay potentially in finding space until after construction. So those were the delays in getting a North County clinic 24/7 available. So we thought that the pilot clinic might be an opportunity to stretch, and without losing any coverage, because everybody in the North County who would request an exam still could come to Valley Medical Center. They're not being denied an exam. There is just the issue of they would come down to Valley Medical Center.
Yeah, and I'm sure Supervisor Smidian will ask additional questions, but it does seem like there's some concern about setting it up that way, just because it might make it harder for people who live outside of the Stanford campus area to sort of know where to go, where they access, and it even now sort of seems like it's being interpreted as mainly for Stanford students.
It being interpreted that way, yes, but it would be within one jurisdiction. So that was the opportunity that we were discussing with them, but it's not that we would want to limit who could have access. It was just this is what we could provide with a location that was available. And the location available is primarily for university under the DPS.
And the issue about funding, additional funding and resources, particularly for the YWCA, for their program?
They're funded separately than we are. There are some state funds that the YWCA can leverage through CalOES, certainly through the Victims of Violence Against Women Act, Victims of Crime, but we don't, as exam teams, have access to those same dollars. So money does come into law enforcement, and that's who, by law, pays for these exams.
Right.
But for operational needs, there is no money that comes in from the state for that purpose.
Yeah.
So there's some different pathways of funding.
Yeah, certainly I think one of the things that we know is that the need for more sites is very great, and it's just then trying to figure out what we can do and what others are doing, and if they need additional resources from the county to be able to continue on with the work.
And they are correct in that by law, the patient does have the right to have an advocate with them, a sexual assault advocate. There was also the concern that if we were to have a pilot project that we would have Stanford advocates available. That's not the case. The YWCA still is who we call every single time we go out on a case. So we would not be calling Stanford for advocates, we would be calling the Y.
And one last question. I noticed that the training for nurse examiners only is offered twice a year. Is there anything we can do to increase that?
That is offered through the state, through the CCFMTC, which is the Forensic Medical Training Center under Cal OES. By law, there is the 40-hour training, and they offer it in January and August. I've asked if they would consider a third or fourth training time, which would be helpful, but that's not available at this time.
Supervisor Smitty?
I see that Dr. Smith might like to weigh in, so I've got quite a bit before we go to Dr. Smith. Just Supervisor Yeager, I think this is a conversation that's going to require a little time, and I know that ordinarily we wrap at noon. Are you okay to stick around?
Yeah, I think we were expecting that we'd go to at least 12:30 or so.
Good, thank you. Let me just turn to Dr. Smith, and then I've got some questions and some comments.
I just wanted to make a recommendation to the board. I think that the issue of funding from the county is a good issue, and when you send this recommendation to the full board, I would suggest that you amend it by suggesting that the board authorize staff to look into additional funding for the representatives. It'll require us sitting down with the two agencies, but we'll be happy to do that. And then the second issue with regard to a location, there is no easy answer to that, but certainly if you direct us to, and whether or not you direct us to, we'll do it. We'll look around for other potential sites that we might be able to lease, purchase, or share in some way so that we can provide the service in a more centralized way. But for the moment, this cooperation with Stanford, I suggest, would be a good idea.
Thank you. A couple of questions. First, we had the beginnings of this conversation. Well, not the beginnings. We had a portion of this conversation both at a board meeting in May and then at a budget hearing later in May. And I can't recall who, if any, among you were there. A lot of folks in the room at the time. But what I want to do today through the chair is try and use the conversation to see if we can do more and do better without anyone who's been doing extraordinary and important work to date feeling like they're on the defensive for having done it. So let me just communicate that at the outset. Thank you for the work you've done, and I hope you view the conversation we have today not as an implicit criticism, but as an opportunity to say how can we do more and how can we do better and how can we do it sooner rather than later. So please take that in the spirit in which it's offered. Couple of questions and then a couple of thoughts about how we might proceed. The numbers are up, and at least a couple of the advocates who spoke suggested, and I'm hoping that they're right, that that's a function of a greater inclination to report rather than a greater incidence of sexual assault. Do you have either thoughts or data on such a thing? I'm guessing that it's hard to parse what the increase means, but if you've got some light you can shed on that, that would be a helpful starting point.
We don't currently have data on that. We do have a new electronic form that's come in from the state, so our current 8-page form is now going to be a 10-page electronic form. That will start to yield good data for us, which will be much easier to access. Currently, I can't tell you what is driving this increase. My gut is that it's both. increase in the amount of assault and increase in the likelihood that they're coming in to report. We are seeing much more injury in our cases, so I can't tell you what the numbers are up for, because we did have an increase that predates Me Too, predates kind of the movements that we're looking at right now.
Thanks, that's helpful. So when we've talked about this before, the concern I've expressed, which I think is shared by the entire board, I rarely feel like I can or should speak for my colleagues, but was about having a single center at VMC. And again, I mean, no disrespect to VMC, you know, your sense of what's convenient or local or comfortable is very much a function of where you live and work. So, you know, if you're in Mountain View, Valley Medical Center may seem very remote, very unfamiliar. If you're in Gilroy, same story. I'm obviously more focused on the North County by virtue of the district I represent, but I want to be clear that the concerns that I express are about this sort of system-wide and county-wide challenge. And the concern that I've expressed before that I think is implicit both in some of your comments in the report and the comments we got today from folks is that folks who have already been traumatized in an extraordinary way are essentially being re-traumatized, or that trauma is being compounded by pulling them away from familiar surroundings, friends, family, just geography, frankly. And so the notion is, can we minimize the need for that? It strikes me from reading the report that we've got, to grossly oversimplify it, two sets of challenges: personnel and facilities. Is that, and you know, I guess you can always add the third one, which is money, but the fundamental challenge to having you know, a robust operation in both the North County and in the South County is finding the right facility and finding the people who are trained and qualified to staff it. Is that, I mean, is that a fair summary? Is that the challenge we've got?
It's a fair summary. I would put top priority one would be the staffing.
Okay.
There is a limit to the number of forensic examiners that are available, and this is not unique to Santa Clara County.
So focusing on that for just a minute, and I had the same question Supervisor Yeager did, which is whether or not there might not be an opportunity for the additional trainings rather than just twice a year. Who is it that would have to decide what at the state level to make additional trainings available? So if we were going to tackle that one, who would we have to go to and say, we need you to make the decision to offer another program or another training?
That would be CCFMTC, the Forensic Medical Training Center.
And just bear with me here, because I'm not quite as tapped into the system, obviously, as you are. Say it again, please.
CCFMTC, I can't remember the first two, but it's the California Clinical Forensic Medical Training Center.
Okay, and do you happen to know who they report up to and through?
CalOES directly. They're funded through them.
Okay. So, and if you could just tell us a little bit more about what their reaction was when you asked about the possibility of additional trainings, that would be helpful.
They were very open to it, but it's just a matter of them going back and looking for funding and them restructuring what they offer in order to be able to provide the third training time.
Okay.
We've also been looking at our training to see if there's a way that we can shorten our training so that it wouldn't be as specific to be training around their availability or their times that they offer their class, so that we can get most of the training done and then we can fit in their 40 hours whenever.
And I apologize because you lost me there a little bit on how our training and their training are integrated.
Their training is part of the 40-hour didactic, but then the rest of the hands-on training, all of the additional like women's health training, the rest of what's required can be done outside of that. It used to be that you would wait until the training was done and then we would have all of our training to follow. But we want to change the way we train so that we can compact it, make it faster so that we can get examiners up and ready sooner.
And is the benefit of that, and again, bear with me, I'm just not familiar with the system, that, I mean, it sounds like we're still dependent on the 2 trainings at the state, but that if we were able to restructure our own training, that we would at least be ready to go and folks would be all set so that the only thing remaining was that state training. Is that the thinking?
Correct.
And what would it take for us to be able to restructure our training in that way?
Well, some of the things that we provided in the report, certainly management structure, administrative structure, so that we can focus on that training, education developer, and more staff to be able to provide the training. We're looking at possibly simulation labs at the hospital. We have opportunity at the hospital that we can train through our resources and make sure that we can shorten that training time.
Thank you. One of the things in a separate conversation that we've done, and I'm looking now to the county staff up here, is when we struggled with staffing and really what were abysmal response rates at the CAN Center, the Child Abuse and Neglect Center, I think the term of art people use is overstrengthened. I just called it overhired and overtrained, meaning we trained more people than we, quote, needed, and we hired more people than we needed, just because we knew that there would be attrition, and that ultimately, you know, if we only hired 10 people to fill 10 slots and only trained 10 people to fill 10 slots, and as soon as you lost any one of them, you were suddenly down 10%, just, you know, to grossly oversimplify. Is there any benefit or merit to taking such an approach? I see Mr. Lorenz leaning in.
So the answer to your question is yes. We do believe that is a strategy. And to Kim's point, the effort to identify nurses has been a challenge. This is a field that is not attractive to every nurse out there. You have to have a certain profile, a particular interest in this, this forensic examination process. So our interest, and if you look at our staffing plan, it really does focus on creating some stability around our ability to develop the staffing resources needed, not only for the current location, but ongoing relative to the future plans to the North County and to the South County. So staffing is the major issue for us at this point in time. And I think we plan, and this is actually to some of the question that Ms. Ellenberg brought up, plan on returning to the board with the staffing plan specific to the budget request and adjustment to address our capacity to address the staffing deficiencies that we see here today, and hopefully get ahead of the curve, because that is critical to the success of this program.
Sure. I'm going to, in a few minutes, maybe more than a few minutes, I'm going to offer a motion, and when I do offer the motion, I'm going to offer the motion to specifically ask that we look not only at those staffing issues, but also that we look at using overstaffing, overtraining, overstrengthening, whatever term we want to use, as a way to ensure that after whatever attrition happens, we're still left in a place where we're feeling that we're equipped to do the job. Let me, on the staffing issue, let me just ask a further question, which is right now the pilot, which I'll get to in a minute, is, as I understand it, in the North County, is designed to serve weekends. Is that the plan?
Correct.
And so Monday through Thursday, for example, the protocol would be to revert to VMC again. Is that the thinking?
Correct.
And presumably, and then is it 24/7 on the weekends?
It would be the evening of Friday until Monday morning.
Okay. And presumably that's because that's when the need is determined to be greatest?
That and the limitation with space.
Okay. One of the reasons I'm probing on this issue is that in terms of the ability to attract staff, and this goes back to Mr. Lorenz's comment, one of the things we've heard, and Ms. Tully's, we've worked on some of these issues with the desire for folks to be integrated with law enforcement so a lot of our healthcare folks aren't anxious to work evenings. And they aren't anxious to work weekends, frankly. And again, in a field where there's, competitive hiring environment, I guess one of the questions I'm asking is would it actually be easier to hire people Monday through Friday, even though that's not the period of greatest need? Obviously, we're all looking, I think, to eventually get to 24/7, and I understand the desire to initiate. But if we could deal with the facility issue, which I heard loud and clear, is there any reason we couldn't move forward on the Monday through Friday evening time?
For the pilot clinic, you're saying, or for?
Well, for sooner rather than later, whatever we call it.
That's part of what we're looking at in the staffing plan that we're wanting to come back to the board with, is to make sure that we have the correct number of people in place at any given time to respond to any patient that comes in.
Okay, so let's get then to the facility issue. What's the facility challenge? And just so you know, I've represented the North County for a very long time. I am familiar with the real estate challenges in the North County, but I'm trying to get a sense for more specifically what the real estate challenges are, or the space or facilities challenges are in this case. And if you could tell us a little bit more about the need for, or desirability of proximity to what I'll call a full-blown hospital, because there obviously are some other options, but they may be less than ideal.
The need to be at this, well, the space that we were looking at is currently a clinic, and it is full during the week. And so there was an issue of going to a clinic, and maybe it would be obvious if you were there with us what you're there for. So it's not as private as it could possibly be. It's not ideal that way. So the weekends when the clinic was closed was when we were going to be able to work with them. The issue that we had was, again, increasing the staffing in order to accommodate 24/7. We were looking at a way that we could work on the weekends, incrementally expand our staff, and then still provide care in the North County.
Okay. And so let me just help me understand a little bit better. So we're not at Stanford Hospital. We're not at Lucille Packard Children's Hospital. We're at a clinic facility somewhere on the Stanford campus. Is that okay? So later this month, I've been working with the staff, and thank them again, to talk about how we can, we as the county can collaborate with Planned Parenthood in Mountain View, for example, on their new facility there. Supervisor Yeager, you may remember a year and a half ago, we thought, well, there was a crisis because they were about to be Planned Parenthood was about to be evicted. And I joke that sometimes things work out exactly the way you planned, except totally the opposite. And in this case, we thought the solution was going to be for the county to buy a building and for Planned Parenthood to sublet from us. Turned out the solution was for Planned Parenthood to buy a building and for us to sublet from them. And if all goes according to plan, I think that's coming back to us later in October. Is that a possibility we've explored? And again, I understand it's sort of a work in progress. I'm just trying to tease out some of the possibilities.
It's not a possibility that has been provided to me to explore.
Okay.
What is the proximity of that location to Stanford Hospital?
Well, it's in downtown Mountain View, actually a little farther north, and so it's 5 minutes away from Stanford Hospital, 5-10 minutes away from El Camino Hospital, and then the other question, obviously, is we've got El Camino Hospital in the North County. We don't have a county health clinic in the North County, subject on which my colleagues have heard me at great length previously, but we do have Mayview, of course, the community clinics in both Mountain View and in Palo Alto at the North County Courthouse. So I'm just, and of course we've got the Palo Alto Medical Foundation, the Sutter affiliate, which is a pretty good sized and substantial facility. So I'm not going to try and tease out the possibilities on each of these, but I guess how clear are we that we need to use the facility at the Stanford campus that's been described?
I'm open to possibilities as long as it's a space that will meet the needs for the exam to occur and the other requirements are available at that site.
Okay. And the issue that's come up, obviously, is the concern about it being limited to folks in the Stanford area. So Stanford is 8,000 acres. It's got 6 different governmental jurisdictions. And the piece I'm most familiar with is the piece that is the 4,000 acres of Stanford land where the core campus is, that's in the unincorporated Santa Clara County, because that's the piece we have responsibility for. I think that's the piece that you're talking about in terms of the Stanford public safety folks, yes?
I can't tell you their exact jurisdictional lines, but whatever is within the jurisdiction of Stanford DPS.
Okay. And you made the point earlier, and I caught it because it's an important point, that it's, quote, not just students, that it's anyone who is either resident or present in that jurisdiction. The reason for that, again, is what?
It was brought to our attention that there was a need for us to have a larger presence in the North County. This seemed like a viable option where we could expand services, again, incrementally on our path to having a full 24/7 North County clinic. But what was available at that time was not there was no space available beyond what was offered for this.
Well, is it that you have a space now, so I'm just trying to get a handle on, is it that the folks who've offered the space have said they'll only offer the space if it's only for folks on the Stanford campus, or is there some physical limitation? I mean, the numbers, while growing, are, I can't believe they're so great that if another person or persons needed the services, there wouldn't be space at the clinic, or are you saying that that is the problem?
No, the clinic's not the problem. As far as using that space, it was just a discussion, and it was what was available right away. Other spaces were going to need different fixes in order to get to what we needed for an exam.
Got it. But if somebody said to you, tell me again why it's not possible for someone from Mountain View to use the space, to benefit from having the space in the aftermath of an assault, but it is possible for someone who happens to be resident on the Stanford campus, what's the answer to that question? And let me just give you, I'm going to be a little bit, if I had a broken leg, no one would say, well, I'm sorry, we don't take people from Mountain View with broken legs here. We only take people from this geography for your broken leg. So I'm just trying to understand why, in this case, somebody's going to say, gee, can't help you here because your geography's off.
This was never intended to be a situation where we would limit who could be seen. It was just that this clinic isn't necessarily going to be one where you can have any law enforcement agency arrive with a patient. There were limitations with who could be there, simply because of the fact that it's locked all night long and nobody has access to it except certain people. So that was the limit for us. Again, we were happy to explore opportunities on any other clinic sites or available space.
What would it take at that site? Because I want to reassure you, I'm trying to be helpful here, not critical of the good work that's already been done, and I, implicit in the conversation is before you can get to here, you have to get to here. I get that. So I'm just trying to think about, is there a way to get to here more quickly and more satisfactorily? So what would it take to say at the existing site, the one that you're planning on using, you know what, we're just going to make that available to the North County law enforcement agencies to use? Who would have to say yes to that? Let's try that.
I think you'd have to speak to Stanford for the medical, not the hospital, but the clinic, medical clinic there.
Okay.
The executive director.
Okay. One of the things that I wanted to ask about is, do you have a sense for the timeline? Because it's described as a pilot, but it seems to me that it's at this point, the thinking is that it's a pilot in almost the purest sense of the word, which is we don't have a plan or a timeline beyond the pilot that's definitive, because we don't know what the experience with the pilot's going to provide and indicate. But you know, I think if there, well, let me stop there. Do we have a sense of what the path looks like, or are we really in a sense of saying we're going to have to wait and see what the pilot indicates?
Well, certainly it's going to be limited by the amount of staff that we can get trained and how quickly we can get that done for us to be able to stretch. But I would say that the fact that it's a pilot was really kind of letting us learn. It was a learning curve for us, what it would take to expand in a small sense, rather than try and open up a full North County clinic and not be ready. Because that's the last thing we want to do, is open a clinic and then have to close it down, which is ostensibly what happened in Gilroy. It's ready to go, but we need more staff.
Okay.
Supervisor?
Please.
Please. Thank you. One of the things that has occurred, and I think everyone can appreciate this, from the time that the pilot was approved or suggested, a lot has changed. There's been a greater appreciation for the level of service that is not just needed in the South County, but clearly in the North County, from a county-wide perspective. And the barrier to actually implementing that pilot came back to the main issue that we have been struggling with, is staffing. And through the course of the past several months, and even during our effort to prepare this report for you and the board, there was a realization that, number one, the program needed a lot more attention, and not only in terms of the staffing structure and the oversight and to bring stability to the program itself, but also around the thinking about the delivery locations. So what I can share with you today is that we clearly understand and believe, as you do and as you are pointing out, that whatever location we establish, particularly in the North County, it needs to be accessible to the entire community. And that is something that we strongly believe in, and that we will make sure that if we do implement, when we do have the staff, that in fact it's available for everyone. I think I too have a very difficult time, and as well as staff, in simply making staff available for a particular segment of the population. So our goal will be to readdress any question around a pilot and its service availability. It is also our interest to look for a location that will serve the community's interest long term. And whether it is with Stanford or, as you've pointed out, other alternatives, which you've highlighted in Mountain View, then we will explore those options at your direction, because that is consistent with what we believe will be coming forward with staff recommendations. So I just wanted to offer those comments to you, Supervisor.
Thank you. I appreciate that. Anything else you'd like to share, any of the three panelists? Because I feel pretty sure I don't know what the expertise of your colleagues is well enough to tap their expertise. So anything else you'd like to share at this point? No? Okay. I should, while each of us is a district supervisor, each of us also has a responsibility to be mindful of the needs of the entire county, and Supervisor Yeager and I happen to be the two people who sit on this committee. But I should underscore that the legitimate concerns of one part of the county, including my district, are not exclusive to my district. They're obviously, as you've mentioned, concerned to folks throughout the county, including the South County area. I think what I'd like to do, Supervisor Yeager, is ask that we direct, in addition to receiving the report, that we direct staff to report back on opportunities to serve a broader population more completely with respect to 24/7, 7 days a week operation, and to describe for our board and the committee, if that would be your preference, to have it come through the committee, what we might do to facilitate or encourage additional training at the state level. There may be an opportunity to engage our state lobbying team, for example, or our state's delegation, or a former member of the state legislature, or someone involved with CSAC to try and provide some encouragement and support for that. So if there's a way that any of the other various resources of the county can support your effort in that regard, I think that would be worth pursuing. I'd also like a little more clarity about what it would take in the way of resources and personnel action to restructure our training along the lines that you've talked about to do our training so that people really are sort of ready to go once they get that last piece from the state. I'd like to see some specific thinking about overtraining, overhiring, overstrengthening, whatever the term of art is at our employee services agency these days. Like to see some additional thinking about location. And again, I don't want to put all this on you. We have facilities of fleet department. We have individual supervisorial offices who sometimes have relationships. I would very much like to, I will ask that the motion direct the staff to pursue opening the facility to folks without regard to jurisdictional limitations. And I know that's been a precondition, as I understand it, from the provider of the space, and that's the reason you're limiting it. And I'd like to see if we can't work through that issue. And again, offer what other resources, including my office and myself, to see if we can't help you move that conversation along. And then to Dr. Smith's earlier comments, some identification of what the financial implications are and the financial needs would be to effectuate what we're talking about. And again, not just with respect to the North County, but also with respect to other parts of the county as well, and also specifically with respect to the services provided by the YWCA and Community Solutions, if they're the other provider who's facing a similar set of circumstances in other parts of the county. And I hope that the clerk's going to say that that was clear enough that it constitutes a motion she can record here today. Have I missed anything from the staff's perspective in terms of areas where you would like some clarity from our board about direction?
No, Supervisor. Thank you.
Supervisor, I hear a request to address space, staff, training, and then the resources to get there. And we can certainly bring that back.
Thank you. That was a much more concise motion than I offered, but I hope you get the drift. One last question, if I could, before we move on. Is the challenge at the clinic that it's a student clinic? Is that the impediment?
One of them, yes.
Okay. And the clinic is operated under whose auspices? Is it ancillary to the Stanford Hospital, or?
That I don't know. I can't answer that. I don't know if they're under the auspices of the university or if they're connected to the hospital.
Okay. Say again? All right. Thank you. So I'll call that a motion, and I'll ask the chair to second it as part of the direction in addition to receiving the report. And again, I want to close where I started, which was by saying thank you for the work you've done to get us to this point. And I hope, as I say, you took this as an acknowledgement of the importance of the work and an offer to try and help you with resources, tangible and intangible, that might not have previously been made available.
Thank you.
Thank you.
Thank you all, and again, and thanks for coming as well. I think we're going to zip along here, Supervisor Smidian. Maybe a brief report on item number 9, or to ask any questions.
Yes, and Mr. Chair, in the interest of time, we do have Alice Nakvi-Mugler, who's prepared a presentation to bring you up to date on the whole person care, but it's really up to you whether you want us to walk us through the PowerPoint or just answer any questions related to the report.
Maybe just answer questions. And I just have a couple. I know we continue to leave a lot of money on the table, and I'm just sort of wondering, and the state, I know, has allowed us to roll it over, but since the waiver ends in 2020, does that mean we'll eventually be leaving that money on the table? As we just don't have enough programs to be able to spend the money.
Yes, and Alice can give you some of the updates with the recent conversations with the state. Of course, some of these things, it's part of the unfinished business that we need as part of justifying either renewal or extension of the waiver. But we know that by taking this direction, and 2 key decisions that we made related to the whole person care. One of them is that we needed deeper engagement within our system, as well as deeper engagement with our community partners. As you know, those are running parallel, so that's supposed to top down. We really have much more collaborative, authentic engagement going on here, which of course takes time in order to be able to activate some of these things. And then the second piece is we auto-enrolled, but we're also learning that to really engage patients, you really have to provide a lot more outreach and support than we originally had programmed. So those are the kinds of things that we've learned along the way. We're not dissimilar to other counties in this regard because the state structured this program with an RFP, and that took time. And then, of course, there was a lot of issues of negotiations of back and forth in terms of the financing and some of these program details. So the state is showing flexibility, as you indicated, to allow us to roll over funding, which obviously, hopefully we can maximize it over the next 2 years. But at least, at the very least, I think it's a much better approach the way we're taking it. Alice, you may want to add a few more things related to that piece.
Yes, thank you. My name is Alice Nakvi-Mugler, and I'm the OSA interim director. We had decided to auto-enroll patients, but we didn't have a robust structure to distribute them within the system, nor training of staff. So I came into the role in February of this year, and I've really concentrated on those efforts. We've met with every single primary care clinic and some of our specialty clinics in VMC that are starting to enroll patients in their own areas, as well as the community partners. We've met with every one of them and looked at some of the issues, and I know that's coming to the board next week. But 42% of our money is being paid related to the per member per month information that we provide to the state, and we have to both get up enrollments and our touches of those patients. The remainder of that money comes from initiatives, and so there are a lot of initiatives on the table as well that are specialized. So, for example, we're operating peer respite now. It will be opening in the next month, but we had to go to an RFP to have people bid on that, and that's a lengthy process, and so it was delayed by a year, really. We're now rearranging where medical respite is going so that we can expand from 24 to about 32 beds, and that will be in place, but we won't be able to get that in place until December. Of all the 1115 waiver programs, whole person care is one of the most amorphous because each county chose its area of focus. It is a Medi-Cal program, and it does not cover our persons that are in the immigrant status because they're usually under temporary Medi-Cal or restricted Medi-Cal. Those will be covered by GPP for their primary care, but they're not covered by Medi-Cal. So we really work hand in glove with the GPP program in that those that are global payment program, those that are not funded are seen in the same manner as those that are funded for whole person care, i.e. by a non-medical provider, and to give care coordination and improve the care for those patients. So this year we've really, or this last 6 months, we've really been building infrastructure to continue. There is word on the street that the GPP will continue, probably for the reasons that were earlier described, i.e. that Medi-Cal, not as many people are eligible for Medi-Cal, and we don't know about the status for whole person care, but it's also being considered for an extension, but we don't have a current status. We will be putting in a budget adjustment in November, by November, to roll over some of those funds again, and we are working diligently to try and maximize what we can get this year, but we won't be able to gain the ground that we've lost to getting to this point, but we certainly are building it so we can be robust going forward.
Supervisor Smitty, any comments or questions?
Mindful of the time.
Right. No, very good summary. Thank you very much. Supervisor, we've got 2 items left, the report from VHP and then also the report improving healthcare effectiveness, including breast cancer screening rates.
One possibility, Mr. Chairman, would be to simply move to receive the report on item number 10 and to continue item number 11 to our next meeting, if that was agreeable to you.
It does work for me.
Great. Well, then, on item number 10, move to receive the report. And then on item number 11, without objection, move to re-agendize that item for our next Health and Hospitals Committee meeting. And with thank you to you, by the way, for the courtesy extended on time on the previous items.
That's fine, and we will then see everybody here on Wednesday, November 14th at 10 a.m.
Thank you, Mr. Chairman.